So just a little bit about myself. Originally, I was born in Sydney, where I did my initial undergraduate training. After I graduated, I moved to the Gold Coast, where I worked for a number of years as a general dentist, before finally moving to Brisbane, where I completed my specialist training in periodontics, and where I'm now working as a periodontist and associate lecturer at the University of Queensland. So guided surgery has become a mainstay of implant therapy, and we see that it's been increasingly adopted by clinicians. This has been partially fueled by reports of superior accuracy in recent randomized controlled trials when compared to freehand surgery. Furthermore, there have been reports of improved patient satisfaction with the use of guided surgery. In a recent randomized controlled trial by Sancho Pichardis, 83% of patients who received guided surgery were satisfied with their group allocation, as opposed to 50% of patients who received freehand surgery. And this difference remains significant even after the surgery was performed. But do clinicians and patients truly understand the benefits of guided surgery? And is guided surgery suitable for every implant case? I'll be addressing these questions throughout my presentation. So just an overview of what I'll be covering. Initially, I'll talk a little bit about guided surgery and the different types of guided surgery, before talking about potential benefits beyond improved accuracy, before finally finishing with my case presentation. So guided surgery or computer-assisted implant surgery can generally be divided into three main subcategories. Cast-based guided surgery, and this is the conventional way that guided surgery was performed, where the surgical stent was manufactured from the dental cast. The guide was non-restrictive in nature, allowing changes in angulations and position during the surgery. The second type of guided surgery is static CAIS, and this utilizes a stereolithographic surgical template, where the positioning and angulation is all predetermined prior to the surgery, and consequently the guide is restrictive in nature. And finally, dynamic CAIS, which utilizes virtual real-time guidance, where the position is dynamically illustrated on CBCT data and fed back to the operator via a monitor, allowing intraoperative changes. So for my presentation, I'll be mainly focusing on static CAIS and to the literature specific on partially dentate cases. So there have been a large number of studies which have looked at potential factors which can affect the accuracy of guided surgery. And what I mean by accuracy is how well the final position of the implant in the patient's mouth matches that in the implant planning software. So these factors can generally be divided for static CAIS into four main groups. Factors related to the image acquisition and data processing, to the design and the manufacture of the surgical stent, factors related to the use during surgery, such as anatomical limitations, and then those related to implant design and site factors. So we can see there's a large number of factors that ultimately can influence the final accuracy of the implant surgery. And consequently, careful case selection and considered guide design is paramount to optimizing the treatment outcome. I'll now talk a little bit about the potential benefits beyond improved accuracy. So as I already mentioned, improved accuracy of guided surgery beyond freehand surgery has been demonstrated in a number of recent randomized control trials, and this is summarized well in a recent systematic review by Tatan et al. In 2020, which showed that there was significantly lower angular, coronal, and apical deviations compared to freehand surgery. However, despite this improvement in accuracy, will your patient thank you for your decision to use guided surgery? And what I mean by that is, does static CAIS or guided surgery facilitate superior clinical outcomes by reducing failures, complications, and adverse effects? A number of studies have evaluated these endpoints of CAIS, looking at different success outcomes and complications such as early failure or biological complications, as well as a myriad of patient-reported outcome measures. To date, however, there's insufficient evidence to support a benefit in any of these outcomes with the use of guided surgery. This is supported by a recent randomized control trial, which compared static CAIS with conventional implant surgery, and despite controlling for the number of implants placed in each patient and the position of the implant, there were no significant differences in the evaluated patient-reported outcome measures. And again, this is supported by no significant difference is supported by a recent systematic review that even after evaluating the available evidence, failed to show significant differences between CAIS or freehand protocols. Okay, so I'll now finish with my case presentation. So this patient is a 73-year-old female who presented complaining of poor aesthetics related to her upper partial denture, as well as poor aesthetics of her upper anterior teeth. A little bit of background about the case. Initially, she had multiple extractions performed due to caries back in 1990. She then subsequently had extensive crown and bridge work performed, which failed prior to her presenting to me for consultation in 2022. The patient has hypertension as well as hypercholesteremia. In terms of her dental history, unfortunately, she was an irregular dental attender. She did report brushing 3 times a day and flossing daily. However, on intraoral examination, there was inadequate oral hygiene around her upper third molars. The patient is also a non-smoker. This is the patient's OPG. At the time of presentation, the bridges in quadrant 2 and 4 had been sectioned, and the tooth 4-4 was a retained root, as we can see in these clinical photographs. Periodontally, the patient had deep probing pocket depths associated with the teeth 1-8 and 2-8, and there was also attachment loss and loss of interdental papilla between most of her anterior teeth. So we diagnosed the patient as having unaesthetic anterior crowns resulting from discrepancy in color between teeth, unnatural tooth proportions and contours. She also had a loss of posterior support and unaesthetic denture. We classified her as having stage 4 localized grade B periodontitis and a 4-4 retained root, which was unrestorable. So in addressing the patient's primary complaint, the 2 main treatment options that we had available to address her denture were to either provide her implant-supported removable partial denture, which would have resulted in superior cleansability compared to a completely fixed option, as well as reduced cost, or alternatively, a complete fixed option, which we envisioned would take the form of 2 implant-supported bridges in the maxilla, a mesial cantilever bridge in quadrant 4, and then a single unit implant to support a single unit crown in the 3-6 site. This option was the patient's preference, and despite increased cost, treatment time, and likely morbidity, the patient opted to proceed with the fixed implant option. So we initially provided treatment for the periodontitis, providing the patient oral hygiene instruction and subgingival instrumentation, as well as extraction of the 4-4 retained root. We then evaluated the patient 3 months after and noted that the patient had achieved periodontal stability. Consequently, we were free to proceed with the implant therapy, knowing that we had controlled the risk factors for perimplantitis. So this is the prosthetically driven treatment planning for the maxilla. We were looking to place 4 bone-level Straumann implants to support 2 implant support bridges, noting that there was reduced bone on the buccal aspect of the 1-4 site, which could have potentially necessitated guided bone regeneration at the time of surgery. This is the prosthetic plan for the mandible, where we plan to place 2 tissue-level implants, one to support a cantilever bridge in the 4-6 site, and one to support a single unit crown in the 3-6 site. So these were the surgical guides which we plan to use at the time of surgery. In terms of considerations in the design, we ensured that both of the guides were supported with at least 4 teeth, with a minimal drilling distance between the guide sleeve and the bone crest. We also had verification windows made evenly distributed throughout the guide to ensure that we could confirm seating at the time of surgery. We felt that a guide approach was suitable for the maxilla, as a recent randomized control trial has shown superior accuracy and parallelism could be achieved with a guided approach as opposed to freehand surgery, and the accuracy was also further lent to by the fact that the implant sites were healed sites as opposed to extraction sockets. In the mandible, we opted for a partially guided implant surgery approach. Reason being is that the wide soft tissue collars of the implants would not have allowed us to place the implants through the surgical guide. At the time of surgery, however, despite all these considerations, the maxillary guide exhibited insufficient fit, and consequently we weren't able to use this guide during the surgery. So why didn't the guide fit? So factors affecting the guide fit has been seldom investigated, as noted in a recent systematic review by Thomas et 2018. However, one of the factors which may have contributed to the poor fit in this case was our decision to use the extraoral scan of the dental model as opposed to an intraoral scan of the patient to design the guide off. A recent randomized control trial has compared these 2 modalities of scanning, but found no significant differences in accuracy between the groups. The study, however, did note that errors could be introduced during the analog to digital conversion models, resulting in incorrect proportions. So we decided as an academic exercise to retrospectively evaluate the potential reasons for the poor fit in this case. So what we did was perform an intraoral scan of the patient's mouth after the surgery was performed and superimpose the two models using the Geomagic software and their best fit algorithm. And what we noted was there was significant deviation in the on the platal aspect of the 223, upwards of 1 millimeter, which would have significantly affected the fit of the guide. And we can see this as well on the digital planning on co-diagnostics. So what this shows us ultimately is that errors can be introduced at any step during the SKICE workflow, and each record should be taken as carefully and accurately as possible to minimize errors. Thankfully, we had anticipated potential problems with the SKICE guide and had manufactured a cast-based guide as well during the time of surgery, and these are the photos of us using that guide. This is a photo of the suturing at the time of surgery and a photo of 2 weeks post-operatively. Again, this is the photo of the surgery for the quadrant 2 bridge, suturing, and at 2 weeks post-op. These were the radiographs taken at the time of surgery. Thankfully, we were able to proceed with the partially guided approach, which we initially planned in the mandible. This is the implant in quadrant 3 and the implant in quadrant 4 supporting the mesial cantilever bridge. These were the images taken at the second stage surgery and at case completion. So just for completeness, we also, these are just the photos of the patient at consultation and as well at case completion. We were also able to perform a 1-year follow-up. So again, this is at case completion and at the photos at the 1-year follow-up. And thankfully, at the 1-year follow-up, the patient reported no complications with the implants or the inserted prostheses. And again, these are the radiographs taken at case completion and at the 1-year follow-up. Okay, so in conclusion, the accuracy of static KICE has been demonstrated, but is not free from errors. And current guidelines recommend a 2 millimeter safety margin when planning guided cases. And because there's the potential for error, proper case selection, careful planning, and considered guide design is paramount to optimizing treatment success. And finally, despite a superiority or superior accuracy being demonstrated, potentially mainly in straightforward cases, there is little direct evidence currently to support reduced complications, improved success, and patient-reported outcome measures with the use of static KICE. Thank you.